Uh, now it's tricky, you know. Yeah, a lot of things.
How are things with you?
Say, how's the surgery there? You only do elective or?
Yeah, we're doing elective now. We are maybe about 50% of our volume back, but we're doing elective cases. Everybody's obviously getting tested.
Okay.
We have a lot of testing, both kind of the 24-hour and then the rapid 15, 30-minute test as well. So we're in pretty good shape. You know, the only thing is that there are still a lot of travel restrictions, even within the country. So anybody who's not from the Emirate of Abu Dhabi, even from Dubai, it's very hard to get here because of limitations on travel within the country.
Oh. Yeah. Dana is online. Hello, Dr. Portnier.
Hey Charles, how are you? Sorry, I was doing double duty. We have another conference running at the same time, so I was on 2 Zooms at once. I apologize.
Okay.
How are you?
He is good. Yeah, looks like you gained
well,
weight.
What's that?
You gained some weight?
I don't know. I'm gonna blame it on the camera view. That's my excuse. Come on. I mean, this It's got to be a bad angle here. I'm having to go off my iPad here. It's all about the camera.
Yeah, just kidding. It looks
no, it's
perfect,
all good.
perfect, fine. Yeah. How's life?
It's Matt.
It's good. It's finally getting back to some degree of normalcy here. We're I don't know. It's an interesting thing. We've got a lot more cases going on in the U.S., but the world is still opening up. So we may be on a course for some problems, but from a surgical standpoint, we've gone back to near normal. So we'll see how that works out.
Okay. Dr. Matt Crow is also online.
Hey, Dana, how are you?
I'm great. I kind of overheard y'all talking. It sounds like you guys still have quite a few restrictions and things like that there.
Yeah, we do. It's interesting. You know, we are doing elective surgery and relatively busy, maybe 2/3 of our volume, half, 2/3. But even within the country, it's still kind of hard to move around. I think they're just being especially cautious, appropriately so.
Yeah, it's I mean, this has been quite the experience for all of us. I think never have we seen a global thing that affects everyone all across the world like this. It's insane. Charles, I had heard that there was a little bit of I don't know if it's true or not, there was in the news media, there was some smaller outbreak in Beijing that had to get some containment done. Has that been calmed back down?
Yes, got controlled.
Good.
Oh, yes. Hi, Manuel.
Hello.
Hey.
I'm on the space. I'm driving a Tesla in the space.
Oh, that's cool.
Or I was just on the Mac.
Oh yeah. Conference. The keynote.
Yeah. Let me find the right one.
Oh.
Yes, this is the right one. Hi, Matt.
Hey, Manuel, how are you?
Great, great. So, what I need to know. Okay. Dana, how are you? Didn't salute you properly.
I'm very good. Good to see you, sir.
As well.
Aha, bağlandık mı? Abi ne?
Hello, Alper. Dr. Salik.
Hello.
Hey.
How are you? Good to see you.
See you.
Selig,
Hello, Manuel. You look great, as always.
Yeah.
Evan.
oh, let me share my screen to see if it's working.
Okay.
You guys see my screen?
Yes,
Yes.
sir.
Yep.
The
Yeah.
video is okay?
Sounds great.
Yeah, it looks
Awesome.
good.
So I'm done.
Tao远上线了吗？
陶燕还没有看到。
哎，
张主任
哎，
Yeah. Hello.
你好
Yeah.
李先生。So this is Dr. Peng Li from our hospital, Beijing Friendship Hospital. He's the head of our endoscopy.
Yeah.
The hospital.
Department of Gastroenterology. Yeah.
Yeah.
Yeah. Hello, everyone.
Hello.
Yeah.
Hello. Nice to meet you.
Yeah. Nice to meet you. Yeah.
Okay.
主任下午好，晚上好，现在应该是。Hello everyone, this is Yaje from Panther Healthcare, and thank you for all your supporting and your participation.
Morning.
Thank
You're very
you.
welcome. Thank you.
Thank you.
Hello. Hello, everyone.
Hey, let me introduce this is Dr.
This
Hao
is-
Zhang. He's our chair of webinar. He's our chair of Department of Surgery, my boss. And he's also the president of Chinese College of Metabolic and Bariatric Surgeons. Dr.
Hi.
Zhang. Yeah.
Everyone. Nice to meet you. Thank you.
So you know Dr. Dana Pottinger. You met him last year.
Morning. Great to see you.
Now, evening. Good evening.
Oh, sorry. Yes.
Dr. Matt Kroll from Cleveland Clinic. Have Dr.
Pleasure to meet
from Brazil. Yeah. Dr. Ponce. Hey. And still waiting for Dr. Torres. Is Dr. Torres online? Here we also have Dr. Guo Weijiang. He's a director of Chinese Commission of Health, the Center for Continuing Education.
Hi.
Hello.
Hello.
Hi.
Morning.
Good evening.
Good morning. Good morning.
Good morning.
Okay. All right.
Can you hear me well, Charles?
Yeah, very well.
Okay, good.
Yeah. That's your office?
Well, I'm still at home. I'm gonna have to go to my real office later on.
All right.
I see Matt Crow in his office in Abu Dhabi, huh?
Abu Dhabi.
Yeah, how are you?
How are you?
I'm fine, thanks.
Yeah. 朱教授，朱善红教授在吗？
Yeah, I'm here.
你好。
Good
so
morning. But in Chinese, good evening.
Evening.
Good morning.
That is Dr. Zhu is one of our discussants for today.
Professor Zhu. Evening. Morning.
Morning. Morning.
All right, so I think it's only Dr. Torres probably gonna go online very soon. You can probably get ready to start.
Yeah.
Yeah. You have a 倒计时 countdown.
Okay.
他给一个倒计时 ，OK。
Okay. Hello, everyone. Good evening. It's my pleasure to meet everyone on tonight's event. This event is one of Chinese Surgical Continuing Education Week events, and its topic is new technologies and techniques in metabolic and bariatric surgery. My name is Guo Weijiang. I came from Chinese National Health Commission, Capacity Building and Continuing Education Center, CBCEC. The CBCEC is affiliated to National Health Commission. It is a government agency with roles of management and implement in continuing education. By focusing on lifelong medical education, the Commission is in continuing. The Commission is to improve healthcare professional abilities, to promote homogeneous development of healthcare services, and to protect patients' benefits ultimately. The Surgical Experts Commission of CBCEC was formed on December 2019 with 6 committees, including Metabolic and Bariatric Committee. Since the establishing of this professional organization, we have contributed a lot to design and delivery of training courses to the surgeons in China and from abroad. Tonight's webinar is focused on the new technologies and techniques in metabolic and bariatric surgery. We have a strong team of faculty from different countries, including Dr. Dana Pottinger and Dr. Jamie Pongsai from USA, Dr. Manuel Galvo Neto from Brazil, Dr. Antonio Torres from Spain, Dr. Matthew Kroll from United Arab Emirates, Dr. Alper Selik from Turkey, and Dr. Shaihong Zhu, Dr. Peng Li, and Dr. Yang Liu from China. I wish everyone can benefit from tonight's webinar. Now, I will invite the webinar chair, Dr. Zhongtao Zhang, to give a welcome address. Dr. Zhang is the Vice President of Capital Medical University, Beijing Friendship Hospital, and the Chair of the Department of Surgery. Please, Dr. Zhang.
Okay. Good evening and good morning, everyone. Welcome to the international webinar on new technologies and techniques in metabolic and bariatric surgery. I'm Dr. Zhongtao Zhang, as a president of Chinese College of Metabolic and Bariatric Surgeons. As we know, obesity has become a global crisis that affects more than 650 million people worldwide. Metabolic and bariatric surgery is an effective treatment modality for this pandemic. However, awareness of obesity and metabolic and bariatric surgery is still not adequate among our patients, healthcare providers, policymakers, and social workers. Currently, only less than 1% of qualified patients has access to metabolic and bariatric surgery, meaning that this specialty has huge potentials in the coming years. We still have high demand in new technologies and techniques based on clinical practice and clinical research. Today's webinar will focus on new technologies and techniques, including intragastric balloon, endoscopic sleeve gastroplasty, CDS, and one anastomosis gastric bypass. I believe this webinar will not only benefit you as a bariatric surgeon, but also benefit your patients by receiving evidence-based treatment. Today's webinar is broadcasted live on multiple online platforms. Thanks to every faculty for your participation and to Panther Healthcare for the sponsorship. I'm looking forward to working together to deliver a successful webinar. Thank you. Thank you, everyone.
Okay, thanks for Dr. Zhang's welcome address. Now I will invite the other moderator, Professor Peng Charles Zhang. Charles is currently the Chief of Metabolic and Bariatric Surgery in Beijing Friendship Hospital of Capital Medical University. He is one of the leading academic bariatric surgeons in China. Besides clinical works, he also has strong research and publication records, and hosts many educational events. Dr. Zhang is Executive Council member of different national academic organizations and associations. Please, Dr. Charles Zhang.
All right, thank you so much, Dr. Guo and Dr. Zhongtao Zhang. So I invite my co-moderator, Dr. Dana Pottinger, to moderate the first talk. And Dr. Dana Pottinger is Chief of Metabolic and Weight Loss Surgery in Duke University. Please, Dr. Pottinger.
Charles, thanks for having me. It's a pleasure to be here, and it's awesome to see so many friends from all around the world on this webinar. Look forward to a very educational experience. It's my pleasure to be able to introduce Dr. Jaime Ponce to give our first discussion today. He is a past ASMBS president and has been a dominant force in the field of bariatrics as long as I've been in the field. And I think he's known to all of us on the call. And today he'll be talking to us about some of the algorithms used with intragastric balloons. So Dr. Ponce, look forward to your talk.
Thank you. You want me to start?
Hey.
I'm going to share my... So can you see my screen?
Yes.
Yes.
Yeah.
So thank you very much to the Chinese College of Metabolic and Bariatric Surgeons leadership, Dr. Charles Chang, for his invitation to give this talk. So I'm going to review the intragastric balloons, and I'm going to touch on all the technologies that have been reviewed and approved in the United States. These are my disclosures, and the only ones relevant to balloons are I'm a consultant for Alberion and a consultant for Reshape Life Science, but I'm going to present the data and not have any conflict on that, on these consultant agreements. So I do think that when we're taking care of obese patients, you know, we have to look at the whole picture. You know, there are patients that are already at the point that they need surgical therapy, those that have more severe or morbid obesity. There are patients that have the lower BMI, and certainly in Asia, even lower BMI can start with diet, pharmacotherapy, and lifestyle change. But there is a middle segment of patients that may get benefit by using some of the endoscopic therapies. And I think that's where the balloons have better role than using it on different segments of the population. So to me, when we talk about balloons, you know, it's an upper endoscopy procedure. This has the potential to be all ambulatory, lower cost, safer, but the efficacy certainly is variable. And we've seen that among the clinical trials and the data that has been published, but may be able to address some of the untreated class 1 and class 2 obesity patients that are on that category in between surgery and medical treatment. Now, in the United States, we did have the first device approved by the FDA in 1985, which was this Garen Edwards gastric bubble. As you can see, it was a cylindric balloon with very sharp edges. Did have a lot of problems with gastric perforation, ulcerations, and ruptures that created bowel obstructions. And the company withdrew the device later, a few years after the FDA approval. Since then, there's been several devices that have been approved by the FDA. You know, we have a single fluid-filled balloon. It's commercially called Orbera. And this balloon was approved by a pivotal FDA trial. It was a randomized controlled trial, not blinded, in which they met the endpoints. You know, more than 30% of the patients had more than 15% excess weight loss. And they also met a secondary primary endpoint with the mean percentage of excess weight loss in the treatment group was more than 25% at 9 months. When you look at the numbers that were more familiar, so the mean total body weight loss on this trial was 10% versus 3% on the control group. And the FDA approved this balloon in 2015. The other balloon that the FDA looked at it is the dual balloon. This commercially was known as Reshape. This balloon has been acquired by the company that owns Orbera, and certainly this balloon is not commercially available. As you can see, this also was approved by a reduced pivotal trial. It was a prospective randomized multi-center trial. I was the lead investigator on this trial, and then we did met the endpoints by having a difference of more than 15% in between the treatment and the control group. And then we also met the secondary endpoints by having more than 35% of the treatment group losing more than 25% excess weight loss. So now we have this balloon also approved in 2015, but it's not commercially available. There's been several publications in the literature, so certainly meta-analysis that shows that fluid-filled balloons, specifically publications on the Orbera, which is the single balloon, And you can see here the total body weight loss at 6 months is 13% in average. The majority of these publications use the balloon and BMIs in the 30s, as you can see there in the graphic below. Post-approval, there's been several multi-center studies. This is probably the most comprehensive one that includes several centers using the single fluid balloon, and another publication also in the same journal, 2018, with a reshaped balloon. I'm going to compare these two publications in the United States. You know, the single balloon has 320 patients versus 200 patients with a dual balloon, 8 versus 7 centers. The BMI is very comparable, 37. And you can see there the weight loss at 6 months is also very comparable, 11.8 versus 11.4%. So even in real practice, real life data, you know, we see very similar results on these balloons. Now, in the United States, we have had some things that have affected the use of the balloons. You know, the FDA have come up with several warnings on the use of fluid-filled balloons, things that were not seen on the clinical trials, but were known to happen internationally, cases of pancreatitis, cases of balloon overinflation that cause obstruction and require the balloon to be removed. And then they warn us about 5 deaths. Then they put another warning about another 5 deaths. And recently they come out with another warning that the balloons continue to have serious adverse events that were not seen on the clinical trials, but it's still in the low percentage numbers. The other balloon that has been approved by the FDA is the O balloon. This is a gas-filled balloon. It's a capsule. You have to swallow 3 capsules in 3 different sessions. The balloon lasts also 6 months. I'm going to show you here a video of me swallowing this capsule. I think Dr. Charles Chang had the opportunity to come and visit me and watch one of these cases in my office. So the nice thing is that these ones can be done in an outpatient setting. Basically, patients come to the office, they swallow the capsule. I can tell you that, you know, approximately 70% of the patients can swallow a capsule. There is about a third of the patients that are going to struggle swallowing the capsule. And those ones we may want to offer an endoscopic balloon. When this capsule is attached to a small catheter, and then that catheter is connected to a compressed can of nitrogen gas that is inflated. Each balloon holds 250 cc's of gas. And then you do this at the session number 1, day 1, and then in 3 weeks, and then in another 4 to 6 weeks, you put the third balloon. The patient needs to have 3 balloons in order to get the effect of that sensation of fullness. When the balloon is inflated, the catheter is being removed, and the patient can pretty much go back to normal activities because there's no sedation, there's no really time down on his normal daytime activities. You do have to have an X-ray. Nowadays, they have a GPS kind of a tracking monitor, so you don't have to have the X-ray features. This is how the balloons look on the X-ray. And this was also done and approved by the FDA through a randomized clinical trial. I was also part of the principal investigator centers. And you can see here the 2 treatment and control group trends on weight loss, the first balloon, second balloon, and third balloon. And they achieved the endpoints by having a difference of more than 3% total body weight loss. Randomized clinical trial, they also met the co-primary endpoints by having 2/3 of the patients losing more than 5% total body weight loss. After the approval, the O balloon also has published a multi-center study. This is 108 centers, more than 1,300 patients. And you can see there the total body weight loss with 1, 2, and 3 balloons. You have to have 3 balloons to get close to that 10% total body weight loss. One of the features of this balloon is the low rate of adverse events. You know, you see very, very low rate of the nausea, the vomiting, the pain, and all actually major events like perforations or obstructions. This is another device that has been approved by the FDA last year in April 2019. It's called the transpyloric shuttle. This was also approved by a randomized clinical trial comparing 270 patients with a BMI of 30 to 40. And you can see the treatment group had 9.5% total body weight loss at 1 year compared to the control group that had less than 3% total body weight loss. The problem with this device is the rate of adverse events. You know, they did have 10% early removals and 10% develop ulcers in the stomach. This device is not commercially available. The company has not gotten the funding to get it into the market for United States. The last balloon that I wanted to talk to you is the Ellipse balloon, which is a fluid-filled, swallow and excretable balloon. This is under clinical trial in the United States, but it's widely available in Europe, Middle East, and some parts of Latin America. It's a balloon that is swallowed one time with one capsule. It's filled with 550 cc's of fluid. It's a buffer solution. And at 4 months, the balloon ruptures spontaneously in the stomach and it gets excreted into the colon. So this balloon potentially requires no endoscopy and no anesthesia. So this is a patient swallowing a capsule. The catheter is a little bit more flexible than what you can see on the balloon. It's a little bit thicker, but it's a silicone tubing. And the nice thing about this tubing is that actually the patient can help themselves and push it down, swallow it. The rate of swallowing the capsule is similar to the balloon, but it does have an ability to swallow with a stylet, and I'm going to describe to you here in another slide. So this is how the balloon looks like on an X-ray. So you can see the delivery catheter. You can see that little circle, which is the radiopaque marker, and the balloon itself. So when you take a plain X-ray and the balloon is inflated in the stomach, you see the marker right there. Now the balloon ruptures at 4 months, and you can get an X-ray and you can see the marker transiting the small bowel. This balloon is not obstructed, it's just traveling into the small bowel, and it may take 24, 72 hours, even a few days to get down and it gets excreted. The features of this balloon, it is not silicone, it's actually a thinner material that is more flexible and it passes through the GI tract and is filled with a buffer solution that actually, what it does, it ruptures a valve. So this valve has a suture that is biodegradable, and so it ruptures at around 4 months. It breaks the balloon, opens it, and then travels into the small bowel. The capsule actually is thinner than what you see with the balloon. So it's a little bit easier to swallow for the balloons, but I will find the similar rate. But one of the features of these balloons is that if the patient cannot swallow, you can pass a very thin wire through the catheter and then force that, you know, patient swallow with a straw, and then you force it down into the throat, down into the esophagus, so the patients can swallow it. So actually the rate of swallowing with this balloon is close to 100% if you take into account that you can do the stylet assisted swallowing option as opposed to the balloon. So these proposed benefits of this balloon is that it requires no endoscopy, no anesthesia, no hard parts transiting the esophagus, no removal required, and it's a natural passage. Potentially in the United States will help to have a balloon that will cost less because there's less things that we have to do. An endoscopy in the United States is fairly expensive, and if you add anesthesia as well. What is the available data on this balloon? April this year, there was a meta-analysis that was published with the data on this balloon. There's not a lot of publications. There's 6 studies with more than 2,000 patients. This is the range of BMI from the studies. And the early removal rate of this balloon is about 2.3%. So it's similar to what you see with the fluid-filled balloons, but the percentage of total body weight loss at 6 months, 4 to 6 months, depending on the reporting of each study, was 12%. So again, similar to what you see with the fluid-filled balloons. Serious adverse events, 3 cases of a small bowel obstruction, 1 case of gastric perforation, 3 patients that vomited actually the balloon, and 9 patients that had early deflation before the 4 months. Similar time frame in April 2020, this multi-center publication that was not included on this meta-analysis was also published in the same journal, same month. These are the centers, all the centers are from Europe and Middle East. And you can see here the range of BMI, 34.4 in average. And the weight loss, percentage of excess weight loss is 67%, total body weight loss of 14.2%. You can see here the rate of swallowing the capsule, 2/3 of the patients, but with stylet assistance is almost 100%, 99% of the patients. You can see here the intolerance requiring endoscopic removal, close to 3%. when you compare this study with all the meta-analysis studies, you know, the weight loss is anywhere in between 10 to 15%. So again, similar to what you see with the fluid-filled balloons. One of the concerns of this balloon is that it's going to actually transit the small bowel, and many will have the concern about the small bowel obstruction. The valve has been improved, and there's 4 generations of this valve, and the rate of partial deflation of the balloon that can cause an obstruction is less than 0.01%. So they have improved this, and it's a rare event that that happens. Now, when this happens, this is a case report published in Obesity Surgery in 2018. The management actually can be done non-surgical, which is interesting because this balloon is very flexible. The only thing that you need to do is to deflate it. So you have here a picture of that case report with a small bowel obstruction. The balloon didn't rupture completely, so it kind of obstructed. So you get a CT scan, you see the balloon obstructed, you get a fine needle and aspirate the balloon and then let it pass through. So actually it can be managed non-operative, which is another interesting approach described on the management of this balloon's obstruction. So how did this balloon compares to all the other balloons? I do think that I'm going to be clinically favoring this because it's a balloon that it requires no endoscopies. It only requires one event. So it's one action, one swallowing of one capsule, and the rest will be a management of their lifestyle and diet and exercise. And so the patient's days off for the procedure is non-applicable because the patients can come in, swallow a capsule, and can go back to normal activities. They don't have to take 2 days off for the 2 endoscopies. The ability to deploy the capsule compared to the old balloon is much better. The need for tracking the balloon kept for more than 6 months is not there because actually the balloon is going to rupture and actually it's going to pass through. So for the most cases, these balloons are not going to require to track these patients in the long run. And the sequential of treatment is much easier. So if you finish the treatment with one balloon and you want another treatment, it's just coming back for another capsule as opposed to doing 2 more endoscopies. So it's less cost, less risk, less time consuming. So I think this will enable us to actually expand the access to more patients when this becomes available. And it has done that in the Middle East and some areas where this balloon is being used. So finally, for whoever thinks that there is no level 1 evidence on the balloons, I already presented all the randomized clinical trials. There is a meta-analysis of randomized clinical trials on balloons. And there is another meta-analysis of data on comorbidities as well. And so level 1 evidence shows that the randomized clinical trials, the balloons with fluid have better weight loss than diet. And there's not enough data to prove or improve the obesity-related metabolic risk factors on the randomized clinical trials. The ASMBS has approved the intragastric balloons as a temporary therapy for weight loss. And so in conclusions, I think the intragastric balloons can help to manage patients with obesity class 1 and class 2. They offer better weight loss than diet and exercise alone. It's an additional tool for management of obesity. It has had a slow adoption in the United States because of the cash option cost and not insurance adoption. There are more devices in the pipeline. Thank you very much.
Thank you, Dr. Ponce. We have time for a brief panel discussion that's going to be led by Dr. Crow, Dr. Selleck, Dr. Zhu, and Dr. Lee. Perhaps the panelists can share some of their experiences happening in their country and pose any questions to Dr. Ponce.
I'll start off, and I think it's very nice that we have such a diverse panel and participants. And I wonder, having come from the United States here now to UAE, there seems to be a huge variation in terms of efficacy and adoption of these procedures. I mean, I know that you've been a part of studies around the world. I wonder what your thoughts are on how it applies to different geographic regions, and is it simply better in certain areas of the world than others?
Yeah, so certainly when you see clinical trials coming from Europe, it's impressive the results that they get there. And I think there are several features there. Patients are in general stay more in town. There's less movement around. Geographically, they stay with more for their physician. Most of those countries have socialized medicine, so they have access to the treatment, the care, the follow-up, so there's no additional cost for the patient. Seems like culturally patients are more obedient and follow the advice of the physicians. In the United States, we've seen on the clinical trials a lower outcomes because patients move geographically. There's more cost associated to their management. I've seen a lot of adoption of these therapies in the Middle East, and you're there. And I think it is related to many factors. One is the less invasive feature. So people are looking for something that is less invasive, and also the cost, is less expensive. Even though they have access to resources, they still have to pay out of pocket in many instances, and surgery can become expensive at some point.
And then I think you made a good point about reducing the actual cost and procedure-related time away for a swallowable balloon. One of the comments that has been made is that prior to placing a balloon, there are certain absolute contraindications to placing a balloon that you would have done endoscopically. And if you'd done a diagnostic endoscopy, you may have seen something and aborted the balloon placement. But obviously, you don't have that opportunity with a swallowable balloon. Is that clinically significant, or is it, do you get that information from a clinical history prior to implanting this that might prompt you to do a diagnostic endoscopy? How does that fit?
This is a great question, and it's always a criticism of the swallowable balloons, both the obalone and the ellipse. And so I do think that you still need to take care of the patient. You still need to do a good clinical history. And if you have an indication for an endoscopy, either patient has previous history of ulcers, reflux disease, or anything that you need to look at it, you need to do an endoscopy to look at that. So that's a clear cut. But what we've seen on the trials, and then we saw that in the obalone trial, and I can disclose that, we didn't do an endoscopy on any of those patients. And then we did an endoscopy when we removed the balloons, and we had 0 findings because we excluded patients that had a significant clinical history, i.e. of reflux or any gastritis. And so for the most part, the incidence of findings on an asymptomatic patient with that therapy is very small. It is true that you may find a case occasionally, so do a good clinical history and still do an endoscopy.
And then I'll have one more question. Any of the other panelists can jump in here too. It's interesting, Charles has put together a really innovative program of 4 topics tonight, but it kind of is absolutely the spectrum. So we have endoluminal therapies that have different goals, and then we have the sledgehammers of the SADI and OAGB to talk about later. How do we get bariatric surgeons to buy into the fact that balloons can be successful, and ESG too, and Manuel may want to comment on this, that they don't have to be as successful as a bariatric surgery operation, that these really aren't interventions that are designed for the same patients that are going to get a gastric bypass, or certainly not a SADI. And the balloons have been around for a while, the technology is improving, but it seems like there's still some hesitancy amongst bariatric surgeons to say that they just aren't that effective, when really they're just comparing it to something like a surgical intervention. It's really never designed to be compared to that. What are your thoughts on that? Or
I think it's all based on setting the expectations, and I think it's been wrong, the comparison of balloons to surgery. There's no comparison. It's a totally different therapy for totally different patients. I think the balloon are for patients that actually are not candidates for surgery, are not ready for surgery, that have a BMI in that range in which they still not quite there. If you have a BMI of 35 with type 2 diabetes, what's the best therapy? Is surgery. So take him to surgery. So those patients that are not quite ready for surgery, you're not going to do a surgery on a BMI of 33 with no comorbidities, but it still has obesity and it still has risk factors, and you still need to manage the patients. And if you have maximized medical options, this is an option for those patients to embrace them into your practice, take care of them. They're going to lose more weight than a diet. And not only that, they can go 2 routes. One is address their obesity and get to a better place, or maybe if they're not successful, they're already embracing your practice that you can take them to the next upstage level of treatment, which it will be surgery. So no comparison. This is not, balloons are never going to be having the effectiveness of surgery, of any surgery, not even the lap band surgery. They're not going to have the duration of that. It's a temporary device that allows the patients to get a temporary management of their obesity. And it can be repeated. That's the other feature.
I would like to comment on that. Can you hear me?
Yes, I can hear you.
Well, the only indication in our clinical practice for the balloon is preparation of a patient who is not suitable for anesthesia at that time. If a patient is suffering from cardiac insufficiency or a pulmonary insufficiency, we place a balloon, and within 6 months, we remove the balloon and operate the patients in a much better medical condition. However, we had 3 patients who denied surgery after 6 months. They said, we're okay. We like the balloon and we don't want a surgery. What we have seen in these 3 patients was that they turned back in 1 year with a much more aggressive diabetes. Because the condition of losing weight and regaining that weight leads to a much more aggressive sort of diabetes. So I guess patients with diabetes who are prone to regain that weight should be warned about this condition, that the balloon is temporary and their weight will come back again, and they might face a much worse course of diabetes.
I agree 100%. I agree 100% with you. So that indication, we don't have it in the United States, which is for preparation for surgery on super morbid obese patients. But that's been described in the literature, and that's used in Brazil and in other places like your country. I think there is a problem with that. So if you're going to do that, you know, that's a totally different setting. You know, those patients are super morbid obese. Those patients have to be taken probably under general anesthesia to protect the airway. They're going to lose weight, but you know that the weight loss is probably not going to be, number one, enough, and number two, in most of the cases, permanent. And so they're going to still need to come back to surgery. I do think that we need to be very clear that this is a temporary preparation for surgery. In the United States, I have an issue with that concept because in the United States, it's expensive to put a balloon in, especially under general anesthesia, to take it out, especially under general anesthesia. And then you have to wait at least a month or so before you do the surgery. You don't want to do the surgery at the same time that you remove the balloon because that thickness of the stomach wall can be a problem. When the patient gets the balloon out, they start regaining some of the weight back. Especially in the United States, we have a big issue with leaving a patient without any kind of treatment. They regain the weight very fast. And so you're losing the time frame for that treatment while you're taking the balloon out and then you're doing the surgery, and it's costing more. So it's not being used in the United States, that management, a lot.
Okay.
Yeah, Professor Pons. So I'm from the Beijing French Hospital. So it's an endoscopist. So I have tried intragastric balloon once in that live demo in our meeting. So I have little experiences in that. Because the intragastric balloon is not approved by the CFDA. So I have the question: why the balloon in the stomach for only maybe 4 months or 6 months get it retrieved? Why we couldn't get the balloon in the stomach for a longer time? Because after retrieve the balloon, the patient will have to regain the body weight.
That's a very good question. So there's actually a couple of, Orbera has made a version of their balloon that lasts for a year. There is another balloon that is an adjustable balloon SPAS that lasts for a year. The reason that specifically the Ellipse made it for 4 months is because they wanted to simulate a 6-month balloon, but they realized that most of the weight that you get in 6 months happens on the first 4 months. And so they didn't want it to leave the balloon for a longer time because then you get adverse events by leaving the balloon for a longer time. I do agree with you that probably we need a therapy that lasts longer, that is not that temporary, not only 4 months. This is what we have from this specific company, and the specific principle of this company is that you can repeat it much easier. So that's a concept that I have to still test it. You know, you have a patient that tested for 4 months, does well, start regaining weight, you can test it again because the concept is easily to repeat it. We'll see if that concept, you know, really flies. Still, there's cost associated to doing it second time and third time. But I agree with you. This is very short therapy, but it helps to embrace patients. This is better than not having anything on them when they require something.
Yeah. Yes. Thank you.
Dr. Pons, is it possible for us to learn the price of endoscopic intragastric balloon placement under anesthesia in United States?
Yes. In the United States, doing an endoscopy with anesthesia can cost as low as $1,000 and as high as $3,000 US dollars. Depending on the facility, depending on the hospital, but it's not inexpensive. And you can ask Manuel Galbao from Brazil. In Brazil, the endoscopies are like nothing. You can do it very, very inexpensive.
Yeah. Yes, indeed. Dear Jaime, your talk looks me think that I live in a different world, like in Mars, because like swallowable balloon here will cost 4 times more than the regular balloon, and including endoscopy. And doing, you see that we have done around 100,000 balloons in my country, so it's a very mature market. And Selig, sorry, your patients were not fit for the balloons. You should just choose, your patient choose very wrongly. You are not the right candidate, and you just get 3. So that's, Jaime, embracing your answer. Surgeons are not ready, or they block their minds to everything that's not surgical. They don't see the other patient that needs treatment and say, this is not with me. And they say, all they're gonna say to you like, oh, I have the patients that regained weight after the balloon. You know what, my dear friend Selig? The world is round, is not flat, as some people think. We do the same with your patients. Your patients come to us to be revised by endoscopy. So you know what? Obesity is a very complex disease, and I embrace Jaime explanation. Those patients are not for surgery, but they have to be seen as patients that need treatment in a chronic, evolving and incurable disease. And especially if you're talking from China. So in Asia, obesity is different. So at lower BMIs, patients get more sicker. So we have to start discussing on that. So you have a cannonball that can really cure aggressive obesity. And we have a softball that we jump in a curve that we can benefit some.
On that note, we had some great discussion. Maybe to keep us on time, we'll pass it back to Charles to introduce our next speaker.
All right, thank you. Let's now then move to the next new technique for weight management. I would like to invite Dr. Manuel Galvão Neto from Gastro Obese Center in São Paulo in Brazil. He's going to talk about endoscopic sleeve gastroplasty in the algorithm for the treatment of obesity. Please, Dr. Neto.
Thank you very much, Charles. Thank you for the invitation. Thank you, the Chinese Society, for the invitation. I'll start by sharing my screen, and I hope it works well. So this is what we're going to talk to you about, bariatric endoscopy. That's not a new field. We are with the balloons 20 years on the road. This is the people that I proudly work with that make my work like looks nice. Also to highlight the pioneers on the endoscopic sleeve gastroplasty, endoscopic suturing, Bertrand Lopez Nava from Spain, Braham Abudayev from Mayo Clinic in US, Christopher Thompson from Harvard. We have done quite some of this work also. So this is my disclosure. You see here, work with a lot of companies, and I have to because it's the companies that produce the device that we're going to use here. So what we have, gentlemen, to offer you in 2020 in terms of endobariatric therapies. So we have a device that occupies space in the stomach that Jaime already told you about. They have device occupied space in between the stomach and duodenum. We have the possibility of alter the anatomy on the stomach, on its bodies, on the body of the stomach. We have the possibility of altering the anatomy of the stomach on the fundus and the antrum, and also part of what patient get in, we can take it out. And that said, you see here that all of those procedures that I showed earlier, they are approved by FDA, so it can be used clinically. We also, as surgery, we have intervention on the bowel. We can detour the passage of the food from the stomach into the bowel. We can also, like you're seeing the bowel anastomosis on like SADI, we can do that by endoscopy using magnets, and we can alter the anatomy in parts of the stomach like the duodenum mucosa orophacy. That said, all of them are experimental. But just jump on our matters that endoscopic sleeve gastroplasty. I think a lot of you might not agree with the definition, but it's nothing we can do because the very first publication put that name, and we have to repeat it you to find them on the literature. So there's a lot of different ways to say that. What we use, and you see here, because you're gonna have, I think we're gonna have in China on the future months. So what we have is this device is a giant needle holder mounted in a double channel scope or a single channel scope. We have this two option channel, a needle holder that we transfer the needle from one side to the other. And we have a PDS 2.0 suture. And we have also a helix that is going to be like a grasper that can get into the deep muscular layer and put tissue inside. And we can do running sutures, interrupted suture, a lot of different suture patterns with that. So this is you to understand. So we start like this: anterior wall, weighted curvature, posterior wall. And then we can do a lot of different shaping. This is the very first one that we cross again anterior, greater, and posterior wall. After we finish, we drop the needle and we will act like an anchor. Then we have like a knot pusher. And then we apply a clip. So with that, in the fast forward motion, we can alter the anatomy of the stomach as suture as you, it might please you. So to show you, this is how we do in practice. We have this helix that is a grasper engaging the deep muscular layer. So we bring tissue inside the two towers. We close the needle that is armed. Then we exchange the tip of the needle. And you see that when we let it go, we already have it passes suture. So we have a suture line like surgery. And that's how we do that. And this is pretty much reproducible on that. So our goal here is to see this animal model, and you see the suture going outside. That's more important because some people have a fetish that the suture will hold that in place. Suture never gonna hold nothing in place in the body. So what holds is the serosa to serosa position. So let's take a look of this hard evidence on animals. So it's a canine model. You see here that we have, after 3 months of laparoscope imbrication or plication, you see that the fold, and you can compare yourself on the macro photo and on the microscope. You see that the serosa to serosa position make it fuse. So if we can be stable for 1 month, for 1 month and a half, the serosa to serosa position outside will fuse and will keep the procedure in place for more time. So what we are doing on that? So there's a lot of different suture patterns that we have. Some of them we have some involvement on that, but the mostly used is this kind of suture pattern. What you're seeing here is the stomach. So on your right side of the screen is the smaller curvature in the caesura. I think someone is with the mic open, and then we have the greater curvature. So you see here, anterior, greater, posterior, then we'll do in a U shape. So one that you can see here in the better design drawing, and the other one that we are using the most is the square shape. So it's just like surgery that we're gonna stop and talk about my sutures better than yours and things like that. Anyway, what matters if you reduce the greater curvature and try to tubulize it. So let me show you. This is a pre-op, a 3D tomography, intra-op. Just take a look or just after the procedure. So it's an impressive change on the size of the stomach. So take a look also with this 3D reconstruction react in the body. It's not our intention to do the fundus, not our intention to do the antrum. The antrum is because all the suture is going to break, and the fundus is part of the procedure, different from sleeve gastrectomy. It's completely different. We can discuss it later from the sleeve gastrectomy. So check the x-ray. Looks like a beautiful sleeve, but you can see up there, you can see a gastric bubble of the fundus. Also, check when you see the reduction from that red is what we reduce, the green is what we have. So in endoscopy, you can check here. This is just after, it's a recent procedure we have done. So this is how we tubulize. We don't intend to tubulize like a sleeve gastrectomy, but you can see the shape here and the fundus that have been sutured. And you can see here, we even suture a lot on the fundus. You almost cannot see the fundus, but it's not our intention not to do that. So how does it work? So you see different pictures, but how it works, look at this beautiful MRI, dynamic MRI that Dr. Brahma Budaya gives to us. So you see on the top, you see the heart beating. On the bottom, near the liver, you see the stomach contracting. So the stomach is still alive. It's different from sleeve gastrectomy. We didn't touch the attachments, the vessels, not the nerves. So it's still capable to relax and contract. So still have an environment of low pressure and high compliance like the stomach before. Just reminding you that when you view the sleeve gastrectomy or a laparoscopic gastroplasty, you have a tube that is high pressure and low compliance. So it's a different animal that we're talking about here. So you see here, this is the gastric emptying. So on your left side, you see the colorful picture is the fundus, and it's 240 minutes after, so you still keep the food there. And this is what we think that helped the most is a delayed gastric emptying on that, reminding you that when you have a sleeve gastrectomy or a laparoscopic gastric plication, you speed up the transit. And you can really see here that it translates on the graphic on the right. So what is the history? How we started? So that is, you can see here that the very first presentation on the SAGES, I think it's 2011 or 12, that we did 4 cases, and a lot of us from US, from Brazil, from Panama and Dominican Republic, we went there and we tried to get the pattern that we should do that. And there was 4 patients, 4 ladies, that you can see here that the effective dropped the weight. And we were in the beginning and talking about the technique to do that. And just in parallel, Mayo Clinic published the very first, and they put the name, endoscopic sleeve gastroplasty, that we have to follow after that. So they also did 4 cases with good result in a very different technique, but those are the very first publications. And then you see here, that's our timeline. From 2012 to now, you see here we begin 1 case, 2 cases, case series, and then very rapidly what we saw is a large case series, then comparative series, then international comparative series, and you got very fast 2017 with the first large series coming from Saudi Arabia with 1,000 cases, very impressive on that. And as we speak now, we are providing to you level 1 data with a merit trial in US and FDA trial. And also we have, and this is very impressive to me, more than 70 papers written about this technique. We have 11 meta-analyses done in such a short period. And again, Jaime explained to you very well, these patients, our target population is lower BMI, 30 to 40, and especially 30 to 35 is that most of the series you're gonna see right now. So just take a look. I didn't lie to you. Look, so how many papers are published over that? I'll drive you over the data right now. So first, it's from my country, from Brazil and Latin America. We have 2 published series. They're from different groups, so that those numbers doesn't mix. And this one is for the less experienced group that start here, and you can see here some data also from the United States, but most of the data is from Brazil. And you saw here 6 months to 1 year, 193 patients, the U shape, And all of them were training in the same way. That's very different from US and from all over the world. They were training in the same methodology on that. And we use, after that paper, the ASG, SMBS way to evaluate endoscopic therapies that is more than 25% assessed weight loss, or more than 5% of percentage of total weight loss with less than 5% of severe adverse events, and it passed. So just check here. It's a little bit confused, but I'll guide you to here. So if you go here on the left side, under the red sign, you see here at 1 year, 15% of percentage of total weight loss. And you have a regression logistic that being male, more or less than 41 years old, and higher BMI predictors to more effective success on that. Also, you see here the adverse events that will be reproduced all over the trials, that we have at moderate 1%, severe 1%, and with 2 patients with paragastric fluid collections, 1 surgery, 1 laparoscope, 1 clinical treatment. So you see, very safe, at least for this paper. And this is our major paper that we produce with centers with high volume and more experience. And you can see here that on the bottom 12 months, we got a 19.7% of percentage of total weight loss with just 1 severe adverse event, was a bleeding that was fixed by endoscopy, and no mortality as the same on that. So you see here, this is the graph of the weight loss. Every single circle, blue circle is a patient, and you see they are very concentrated near the red line. So it's like the deviation is not that big. So it's a very interesting results on that. Also, we can see here that obesity class 1, so the lower BMI patients have a better performance than the obesity class 2 on the graph. So that again reinforcing what our target patients. And the first big series you see here is impressive series, was published from our friend Al-Qahtani from Saudi Arabia. 1,000 cases, as you can see here, very fast. We have patients that we estimate 15,000 cases done. So this big series, what tells us, I will guide you to that, that on the bottom, you see here, they achieve, bottom left, 14.8% at 18 months of a percent of total weight loss. Severe adverse events, 2.4, there was no mortality. And the main complications, 0.7 was blood loss. And they have, I think, 2 interventions revised with laparoscopy. And how it goes after, how we do that. So you see here in the inferior right, they have redo that 5 cases on the bottom, and also they have converted to sleeve gastrectomy in 8 cases with uneventable. In the center, on the bottom, you can see here that comorbidities were resolved also with the weight loss on those patients. So case series versus multicentric. So we evolve on that. This is one of the very first. We tell the history of this procedure, but as we tell the history, how it's done, devices, suturing pattern, we gather some results. You see here in the inferior part that more than 100 patients, almost 200 patients, 12 months at 17.9% of total weight loss. And we discussed that the suture patterns should involve at least a triangular type on that one. And then we have this index paper that's very important, 248 patients, 2 years follow-up in different centers. You can see here important centers like Madrid on the pioneers with us, Rochester, Mayo Clinic, and New York Cornell. And you see here that the total body weight loss, if you go to the P side on the right, you see here that was no different among centers doing suturing differently. So it's interesting to see that. And in that paper, you see here that 84% achieve at least 10% of total weight loss. That it's enough to get better, much better, and improve the comorbidities. If we apply a more strict way to follow those patients, that's intention to treat, meaning all the patients that we don't find, patients that don't consent us to follow up, every patient lost, you should understand as a bad result, even that they are don't. So 52% is very significant. If you apply that to gastric band, is more. If you apply that to sleeve gastrectomy, around 60. So it's very interesting result on that. Long-term results, most of the data is now reaching 2 years, some are 3, but you see this solid publication presented in DDW 2019 from Cornell. They could follow the patient for 5 years. So 89% follow-up rate, impressive follow-up rate, and it is explained because most of those initial series, they were around the Cornell health system, and they could really follow those patients. And you see here that 70% of the patients keep at least 10% of total weight loss, at 5 years. And it's very interesting. And the mean percent was 14.5. So it's very preliminary data on long term, but you see here on the bottom, 5 years, just follow from the left to your right, and you gather to 69% of the patients that get at least 10% of total weight loss. So you see here is a very, very confused. They are all the patients that they follow for 5 years, and you see here 3 different on the red, 3 different BMIs, I think 30, 35, and 40, and how they progress during time. So you can follow by your own eyes. Comparative studies, how it compares. So the very first comes from Cornell, was a retrospective data compared with the historical data that the endoscopic sleeve gastroplasty performs better than band and worse than sleeve gastrectomy as expected. We go even further. So we did this trial in Spain. So it was an oral presentation of Obesity Week 2017, and it's almost ready for publication right now. So you see here 2 years follow-up. We compare from the left to your right, endoscopic gastroplasty, sleeve gastrectomy, and laparoscopic plication done by robots. Suppose that's a very nice way to suture. So you see here, down on the left, you see the morbidity. We have 1.1% of morbidity in endoscopic, compared with 4 and plus with laparoscopy. Didn't have any surgical revision on the endoscopic side, no mortality, but we have even reoperations on the surgical side, and it was done with a center that was the most experienced center in the whole Spain, and high volume on that. So it's an interesting way to see that. Look at this 2-year data. If you compare BMI patients on our target on BMI below 40, you see here that at the end there was no significant difference in terms of weight loss. And that said, we have to be fair on how we follow the patients. You see here on the left side that there was much more patients that fail on the endoscopic side when you compare with patients that fail for the surgical sleeve and plication. But it's a very interesting comparison to that. And you see here, this is the cover page of one of the most important journal of gastroenterology, showing a paper comparing a sleeve and endoscopic sleeve gastroplasty. I don't think they should be compared, but people will compare that anyways. So that's why we're presenting you the data. Pooled data. So just take a look of this general here. So I just put to you more than 1,600 patients on different perspectives here, different publications. Look the results. And the idea of this slide is to blame your attention. The results are like comparable, different groups, different countries. And you see here as the same as a severe adverse events, as you can see right now. So someone is with the mic open and just said a very bad word in Spanish, not Jaime. So let's go and move forward. This is a meta-analysis. So this is all the groups that published over endoscopic sleeve gastroplasty. They did a meta-analysis. And with, I think it was 8 papers, and this is hard to find here, but just go to the bottom. They see the losango, the red losango of meta-analysis point to more than 15% of total weight loss. This one is gonna be easier. So this one here is São Paulo University. It's a new meta-analysis, and you see here that they got 8 studies, almost 2,000 patients. The percentage of total weight loss, I'll guide you to the capital letters here, 24 months, you can see here, 14.85% on that. And also the excess weight loss goes to 60% at 24 months. and the severe adverse event, the pooled severe adverse events, is 2.26%. So it's very interesting from that. You can see more clearly. That you can see here, this is the mean percentage of total weight loss of all of those at 24 months. Just check, and you see here 0 in the middle, and then 15, and then 20. So you can see here that Losango fits on that. And level 1 evidence, as we speak, is being produced in US by the Merit trial. So Braham Abu Dayed, that the picture that's missing here is Eric Wilson from University of Texas. Nathan Zundel and myself, we gathered the proctorship of those. And it's a prospective randomized control trial. And you see these important institutions, Mayo Clinic, Cornell, UT, Harvard, Hopkins, and a lot of very good private centers also. So this is how it goes. 200 patients, 80 will already randomized for the procedure, 120 for diets, and then they will be crossed after 1 year. So we finish enrollment, and it sounds that it's going good, and we're going to present the preliminary results this year. So I think we are fulfilling all the data that we need to. And I will finish that showing that to you that this is the Texas Heart Institute, and I think Dana and Jaime and Mart will recognize that. An open heart surgery on the 70s. Look the attention that we are driving to that. So let me show you in India in 2017 that I have to paint myself in blue to recognize me. That's the same kind of attention. And you know what? We are not contaminating the field because we can't. And for sure, this is pre-pandemic one. So with that, I finish, and I thank you very much again, Dr. Zhang, for the invitation, and Chinese societies, the opportunity to be with you. Thank you very much.
Thank you so much, Dr. Manu. Dr. Manu is one of the pioneers of ESG, and he teaches a lot of surgeons in the world. And that is very good experience for us to learn from him. And we have a few discussions, and any questions for Dr. Manu, or you have any comments?
I have a comment, Manuel. Great talk, as always. And I think in this forum, there's probably a lot of interested surgeons to figure out how to incorporate these new technologies in their practices, which is probably largely why they've tuned in today. ESG is a tough technical procedure from an endoscopic standpoint, and there's a lot of variability in terms of how it's done and then how patients respond to it. So you have a challenging technical procedure, you have variability in how it's performed, different techniques, which I know you're working on, but then you have the patient as well. And regardless of what intervention, a balloon, ESG, SADI, OAGB, there's variability in terms of how patients respond. Do you think that ESG will be ever something that we can standardize so that it can be more generalizable to the average bariatric surgeon?
Sorry, I miss you.
Do you think it'll ever be generalized?
Are you guys listening to
ESG?
me?
Can you hear me? Manuel?
I think he got frozen.
All right, you're up then. Can ESG be performed by the average bariatric surgeon consistently?
I think he's offline for some reason.
Yeah, all right.
Oh, he's back.
I'm back.
Yeah.
I'm back. Well, some glitch here. Yes, Matt, if I understand right, how to fit the procedure to the patients, it's the same. It's the same difficulty that we have with surgery. So what I think is that we need to find and select the patients better, and because nothing works if you just put a balloon. Nothing works if you just do the surgery. So it's that maturing the system that I can embrace and take care of the patient. This is the obesity has these peculiarities. If you just do a procedure and let the patients on the woods, you're gonna fail. So understanding that, and what I see is a lot of surgeons that gonna use those tools to attract patients, not gonna follow and not gonna do it right. And how it compares, and also Matt states, it is indeed a complex procedure to be done by endoscopy. But if you just understand that bariatric surgery is one of the most complex surgery, and we are able to train people, so that can be, how can I fulfill that is with the proper training. If we properly train the ones we're going to use and not just put the device in their hands, we're going to have good results. And I think is what we have in Brazil. So we take responsibility of getting the method, spreading the method in the right way by training people. And you saw here the 2 papers with a considerable amount of patients, almost 600 patients with no mortality, with a very low morbidity, and almost the same results on that. And this is due to training. And that's bariatric surgery. It passed to the same problems on the beginning. I think Dana have saw that. People just jump on that, start doing bariatric surgery, and that's just disaster. Antonio also saw that. And then the societies, and we all embrace training and how to get our trainees through the more complex procedures.
All right, great. So the Dr. Peng Li is now he in our hospital. He's doing some studies on the ESG. So you have any comments?
So only some animals, some pigs. So maybe it's less than 10 cases on the animals, but never tried on the patients. So I just wonder, it's why I try, it's the system overstage. What? Why try, the system overstage to the pigs? Because I don't want only to perform this kind of operation for the overweight patients, obesity patients, but also for treated patients have their, the worst events of the fistula. I want to use this kind of system to treat the patients of fistula. I have tried several cases and all succeed. It's a very good, it's a result for the patients of fistula. It's not for the patients. Just I wonder, how many cases should, for the new beginner to fully acquire the technique?
Well, this is a tricky question. But here in Brazil, in our training program is that they come, we perform didactics, they see a live case, then we go to the lab, to the boot camp in the lab, 3 or 4 hours of suturing. And what happens later is that one of us go to proctor the trainee on the side with at least 3 cases. So after that, if we see they are good, they start doing cases with the technician from the company. And then if we don't see that they are good enough, we do 3 more. But I think that after 5, you're going to be able to do by yourself. After 10, you're going to be comfortable. Are you going to master the technique after 20 or plus? And it's just an estimation depending on how skillful you are.
Yeah. So for the first procedure, I just spent 2 hours for the first peak. But for the maybe the 9 or 10th peak, only half an hour. Yeah, I think that's okay.
See?
Yeah.
Yeah. All right, Dr. Selig, any comments?
Well, just a question mark in my mind. What we have seen in the initial case of sleeve gastrectomy was an increasing rate of failure after the 3rd year. But when I took a look at Manuel's data, I can see a continuous success. And I couldn't understand why we don't see the rates of failure that we have seen in sleeve gastrectomy.
You see, you are the champion of those questions. You should give a big smile, open up your heart. Don't close your heart. Don't be like this. You see, you're a friend. Let me tell you, you didn't see the failures because it's too new. So the critical mass of patients didn't reach enough time to start failing. And you're gonna see failures. Don't worry about that. And it will fail you. It's not as good as a sleeve gastrectomy. It's not supposed to replace. So relax, everything is okay. But it's different, and that's for different patients. For instance, the procedure we're doing, they are not refluxogenic. That's not a single case in 15,000 cases that didn't have reflux before, now have reflux. And that's something that we have concern. So it's a balance. We're not gonna be as effective as you guys are, but we're not gonna bring the complications that sleeve gastrectomy has. And then we have to balance and offer in a very fair way to our community, to our patients, then to decide. That said, with a lot of increase in cost, the new drugs like GLP-1 analogs are helping us in very selected patients. We are doing a trial right now, and we are having results like having a mixed procedure in the stomach and the bowel. So it's amazing how these new drugs can help us, and will help you also on that set. But again, relax, everything's fine. We're gonna fail also, don't worry, but we're gonna succeed as well.
Great.
Okay.
So we have another discussion who is Dr. Zhu Sai Huang. Dr. Zhu, are you aboard? Are you online? Dr. Zhu Sai Huang. All right, maybe he's offline. And Dr. Ponce, you have any comments on about ESG? You compare with gastric balloon or?
Yeah, so this is very interesting. So the ESG, actually, I will put it on a segment of procedures that are a little bit more effective than what you see in regards to short-term and mid-term durability. ESG, again, I think it's a mistake to compare it to surgery, because surgery is designed to change the anatomy more dramatic in a way that you have more longer duration. I do expect that the ESG is not going to be a long-term duration procedure for the most part. Duration can be anywhere in between 2 to 5 years, but that's going to be a time frame in which the patient is going to have to adapt and is going to decide which route is he going to go. Now, can the ESG be repeated? That's another thing that Manuel has embraced, and it can be repeated. Now, we have to be careful, because some of these cases, when they are converted to surgery, they can create a higher incidence of problems, especially if you are not familiar with what it was done, if you're stapling more than 2 folds of the stomach. And so you have to try to unbundle, and sometimes it's not as easy as it sounds to do the surgical conversion. One of the questions that Matt Crow had for you, Manuel, that you kind of didn't pick it up, is that we really need to standardize the way that we do this. I think there's many ways of doing it, and I think that makes it us a little bit more random in a way. Well, the way that I do it is better than the way that you do it. So we need to standardize what we're doing so we can get the outcomes that we need to do. And same thing with new versions of this. For example, the POSE and the POSE 2.0. Those are 2 new applications with different device that also needs to be standardized, because we already learned that if we do it one way, it may not be as effective as doing it another way.
I fully agree with you, Jaime. Fully agree with you. We have to standardize, and it's a dream. And I can say to you that we have to standardize the gastric bypass. We have to standardize the SADIs. We have to standardize the sleeve gastrectomy. We have to standardize the OAGB. It's hard to. When we involve suture, people start to diverse. But what we see is that most of the people are doing, they're using the U-shape, and it will get better as people do more. So there is a learning curve. So the beginning of the case is not going to be as the same results at the end of the case, because you have to perfect the sutures. And it's something that is hard to. But you saw that in Brazil, we were able to do like experiment and train everybody in the same way. So we have pretty much the same results on that. But I fully agree with you. We have to keep trying to standardize our bariatric procedures, endoscopic and surgical like that.
All right, thank you so much, Dr. Manuel. Now let's move to the next topic. let's move to the next topic. Dr. Partenier going to moderate.
It's my great pleasure to introduce Dr. Torres, one of our past IFSO presidents and a lifelong innovator in our space. He's going to talk to us about a topic that he has really championed and driven to the spotlight in the last few years, the SADIE-S procedure and how that fits into our world of bariatric metabolic surgery. Thank you, Dr. Torres.
Okay, thank you so much, Anna, for your kind introduction. Let me share my screen with you guys. I'd like to thank, the Chinese College of Metabolic and Bariatric Surgeons organization belonging to the Chinese National Health Commission, and especially to my good friend Charles Zhang for this kind invitation to share with you with some friends like Manuel and Jaime and all these guys over there as a speaker. It's my real pleasure to be here. I have to say at the beginning, every time Manuel and Jaime we put the human being, I mean the surgeon, in every study, the way of standardization is very tough, because it's not the same to give pills to the patient than to give some surgical endoscopic maneuver. But said that, let's go to my topic. It's going to be the role of single anastomosis study procedure in metabolic and bariatric surgery. So I think, okay, I cannot go through okay, let me, okay, there we are, I'm sorry. Okay, this is my, disclosure regarding the procedure. We are now performing a 22% of our cases study procedure we do sleeve, we do Roux-en-Y gastric bypass, and we do revisional about 12% of our patients. We don't do one anastomosis gastric bypass in our department. The SADIE procedures coming from mal-absorptive procedures is the Scopinaro or video pancreatic diversion with this picture with a very short common channel of 50 to 75 centimeters. Then, after having, for solving some problem, Hess and Tom de Mister and Picard Marceau in US and Iseto Baltasar in Spain, they introduced the duodenal switch, increasing the length of the common channel and adapting 250 of the alimentary tract. So the idea was a new procedure, for improving the complication coming from the old BPD Scopinaro's approach. So, the way of we were performing a standard duodenal switch and then laparoscopic duodenal switch, and then we thought in particularly the role of some hyperabsorptive approaches. Our hypothesis was in 2007. It means that is almost 13 years ago to perform a duodenal switch, but just one loop. This approach will simplify the surgical technique and probably to decrease the possible complication, because we're enlarging the common channel without jeopardizing the medium and long-term results. So the aim of the study was to get an effective surgical technique with a low complication rate and less secondary effect than the standard Roux-en-Y duodenal switch. So we were coming from the Roux-en-Y gastric bypass, so the Scopinaro procedure to the duodenal switch and to the one anastomosis duodenal switch, and coming from the Roux-en-Y gastric bypass to the one anastomosis gastric bypass with this confluencing in this new procedure. And here you can see a clip, showing we will try to do not very restrictive, putting a 54 bougie inside the stomach for performing a wider sleeve than we do in a standard operation. And then we go as far away as the duodenum as we can, close to the pancreas. Our limit is not the gastrointestinal artery, it's going downward to preserve as much duodenum as we can. And then we perform a tension-free duodenoureostomy. Here you can see how the surgeon can manage by himself with 3 trokers. The camera, left side of the left hand of the patient, of the surgeon, right hand of the surgeon, and performing, you know, and no tension duodeno-ileostomy. We do 2 layers anastomosis with absorbable 3O buildup, and then, as you can see here, how the anastomosis can be performed without any tension and without any problem. So, this is a summary about how to do a surgery with the SADIS procedure. We start, as you said, in 2007. We now have operated more than 500 cases. And we perform the anastomosis. We start at 200 from the ileocecal valve as a common channel. Then we change to 2050 centimeter from the ileocecal valve because we had to reoperate some patients. 8% of our patients submitted to 200, our first 50 patients. And then we started in 2009 in performing studies as a second step. And now we have even some patients with 300 centimeter of the common channel. Now we have more than 160 patients, medium or long-term result follow-up. I have to point out, to highlight that our percentage of follow-up is very high. Our endocrinologists, we work in a public national health system, allow us to, perform a follow-up of 71% globally of our patients. And here you can see the number of cases in US. Long-term, 108 months after the operation, how the stable load was homogeneous. And here you can see overimposed our experience 7 years in our 168 patients, mimicking perfectly, the result of the standard Roux-en-Y duodenal switch. We published our result with this approach in very metabolic patients, obese diabetic patients. We proved in SOAR in 2015, and now we updated our data, and here you can see how is the patient, the complete remission of our patient, consider remission, no treatment with one hemoglobin A1C less than 6%. And here you can see 5 years after the operation, 47% of our patients with initial treatment with insulin were under remission. 89%, 90% of our patients under initially oral therapy were under remission 5 years, and globally measuring both procedures, 72% of our patients. But it was only not the quantity, but also the quality. As we maintain this antropyloric area, the way of controlling the glycemic profile of the patient was different than the Roux-en-Y gastric bypass. We observed some years ago in two patients, one submitted to SADIS and the other one submitted to Roux-en-Y gastric bypass 5 years after complete remission of their type 2 diabetes. And here you can see submitted to the meal test how the patient with a Roux-en-Y gastric bypass, at the end of the day, he got to control their glucose plasma level at the same time as the study, but the way at the Roux-en-Y got this aim was up and down with some episodes of hyper and hypoglycemia, very homogeneous study. So we decided to perform a very controlled study in 12 patients after Roux-en-Y gastric bypass and 12 after studies, 5 years after the complete remission of their type 2 diabetes. And finally, here you can see we found that the percentage of, we submitted the patient and monitoring, continuous glucose variability monitoring, and we observed that the percentage of time that the glucose level were under 70, it means hypoglycemic was higher in the Roux-en-Y compared with the studies. And the percentage of time that the glucose level was in normal range between 70 and 140 was better in studies compared with the Roux-en-Y. And the percentage of time that the patient was hyperglycemic, more than 140 milligrams, was worse in Roux-en-Y compared with the study procedure. Then, this study, this investigation has been reproduced in Italy by Marco Raffaelli and Gertrude Migroni, these endocrinologists, performed with Francesco Rubino, the approach, and they studied, the effect of the study procedure on glucose tolerance tests comparing several bariatric procedures. And here you can see how the way of compare studies with BPD, very similar, regarding the glucose level and the insulin before surgery and after surgery, compared with the sleeve gastrectomy and the Roux-en-Y, much better comparing studies with this other surgical procedure. So studies regarding the control of the glucose profile was much better than the Ruan-Y, much better than the sleeve, very similar to the standard Scopinaro classical procedure. So we also are performing some studies comparing Ruan-Y and studies regarding, the body composition analysis, showing us that studies is as powerful as Ruan-Y regarding reducing the fat mass after the operation, and also the percentage of fat-free mass in both patients, increasing these parameters. So all this study of this experiment has also reproduced in the US. All of you guys, Dana and Matt, the experience in Utah by the group of Dan Kotan with a huge number of patients, more than 400 patients. And here you can see how the very few patients were not able to get lose a percentage of weight loss less than 50%. Which is the range of success or failure. Very few patients were under this mark of 50% of sustained weight loss. Also in Russia, Yuri Yazov also reproduced operating with studies more than 500 cases with very, very few complications. So it's going to be reproducible in other places. A very important issue or topic regarding the study procedure is if there is a role of this procedure after the epidemic sleeve gastrectomy in all over the world. There are many options, you of course know, and this is a debate, but studies can, be very nice alternative in this issue, because we preserve the sleeve and only you perform one anastomosis, don't touch a previous operated area, which can be tough for many surgeons or many patients. And the sleeve is good. We are showing or seeing the result of endoscopic in the sleeve and the surgical in the sleeve. So the sleeve is nice. It's working. Take advantage of it. Why to destroy compared to Ruan-Y or one anastomosis gastric bypass? I don't think going to be a nice strategy. So this is a clip, very quickly for the sake of time, how we are working in a non-touch area. We don't touch, the upper part. This is virgin area. The surgeon can dissect the duodenum very nicely, as you saw in the previous clip. We have to pass, the duodenum and secure with a vessel loop or a tape, whatever you want. Excuse me. And, after the dissection, we divided the duodenum. We are, in these cases, as a second step, we operated the patient from the left side of the patient. We don't open the legs of the patient. In many cases, it's not necessary. The patient is thinner, the dissection is much more easier. So here you can see, we divide that, and then we count the bowel from the ileocecal valve. We can choose 250, 300, or the very, not very heavy patient, even 350. And then, in this patient, after losing weight, it's much more easier, no tension, nobody is putting tension on the anastomosis, nobody's pulling up, pulling back, and you can perform a very, very comfortable anastomosis, again, with absorbable part-based suture. We use 2-layer anastomosis. Here you can see how nicely you can do that. And what about the result of this procedure? Okay, here you can see we are recently published, just I think it's online published in 2020 in SOAR, our result regarding this approach. The studies used on a second step after failed sleep or not getting a nice result. And here you can see regarding, depending on the BMI, how, the result, the patient with a 5-year follow-up is very nice regarding our initial follow-up of the patient. And here you can see the result regarding the same weight loss, the total weight loss, more than 35%, 5 years, 35% total weight loss at the BMI, very nice. Also, we study the differences between having a BMI less or more than 50 BMI at the beginning of the procedure, and the time of the surgery, more than 3 years and less than 3 years, and the excess weight loss after sleep, more than 50%, going to be better than less than 50%. I think it's going to be very nice result. Regarding this study, we observed how after sleep, the patient improved in his or her glycemic profile, hemoglobin A1C, and the percentage of patient of therapy. But after studies, much better. Glucose level, hemoglobin A1C, and the percentage of patient without any treatment. But of course, we have to pay some price regarding the supplementation. After sleep, 24% of our patients didn't need any supplementation, but after study, no patient didn't need any supplementation. All the patients after studies are supplemented. Going to be very important. And this is a very nice study coming from Holland, comparing for failed sleep, studies, and Roux-en-Y. And it's going to be a very nice result favoring the study procedure. Even if you can see in the demographic characteristics of the patient, the patients submitted to studies were heavier, 45% BMI, compared with the 39 the patients submitted to Roux-en-Y gastric bypass. And here you can see the numbers 2 years after the operation. Here you can see how, the patient under studies is still losing weight 2 years later. But the patient under Roux-en-Y is even regaining some weight. And the percentage of short and long-term results are very similar, even worse regarding vitamin B12 in the Roux-en-Y logic as unstable regarding studies patient. And here you can see the conclusion of this paper is that, the Roux-en-Y is an alternative after failed sleep for GERD or some technical problem in the sleep. But when you are looking for weight loss after failed sleep or weight regain, going to be, 72 patients of the Roux-en-Y will regain weight as a part of their lost weight 2 years later. On the other hand, studies are going to be much better as the time goes by. And again, we compare, we recently published 2 weeks ago in SOAR also, our study comparing studies procedure versus one anastomosis gastric bypass in conjunction with the German experiment of Markus Reiser and Martin Bursen. And here again, we compare 42 patients with studies and 42 under one anastomosis gastric bypass after failed sleep. And even you can see here the result 3 years after the operation, a little bit better after studies regarding the total weight loss and regarding the state weight loss. No significant differences between the two procedures 3 years after the operation. But regarding the comorbidities, the bile reflux, because one anastomosis gastric bypass doesn't preserve the antropyloric bile, going to be 26% in the one on OAGV compared with 4.9 in the study procedure. Again, another piece of evidence. I'm not becoming a practitioner. As I told you, we also do 25% of our patient studies procedure. But I think, it's a modified BPDDS. It's going to be a new ePathology procedure to take into account to offer in some patients, especially in very overweight or very metabolic. Makes sense because it's a modification of the very checked over the years procedure, the donut suite, the standard Roux-en-Y, preserve the sleeve, preserve the antropyloric anatomy. We don't retain antrum, no needed Roux-en-Y, and we don't close any mesenteric defect. And here you can see, a revision, a review we do with the American colleagues, studying what's going to be the increase of the BPDDS in the United States during these couple of years, these 3 years, from 2015 to 2017. And here you can see if you have a look to the total number of BPDDS, from 2015 until 2017, increase of 63% of the number. Very few numbers, but a huge increase. But when we have a look to the revision procedure, the increase of BPDDS, including studies, is 114% in the last 3 years. So this means, in my opinion, something. Probably Donald Sweet going to be no way of going back. It was the image of the First World War in Europe. But after the introduction of single anastomosis gastric bypass, probably, we guys can cross the line dividing us, one border at the other, and to make the peace between all of us. So I think the Circle de Sussex is a multidisciplinary team, and sadly going to be a nice option to treat patients with bariatric and metabolic problems. Have been my pleasure. Thank you very much for your kind attention, open to your questions. Thank you.
Dr. Torres, thank you for a great speech. We'll get to a moderated session. Before we go to the moderators, I had one quick question. In our practice, based on sort of the work you've done, duodenal switch and its variants like the SADI have become about 15% of our practice in response to sort of the failure rate of other procedures. Some of the challenges, though, as Manuel pointed out earlier, all of our procedures have a failure rate. And sometimes these more malabsorptive procedures, when they fail less on the spectrum of weight regain and more on the spectrum of protein caloric malnutrition and vitamin deficiencies. Have you changed anything in your practice in regards to how you select these candidates and how you get them to follow up to try to catch these issues?
Okay, the first thing, thank you, Dana, regarding the question is very, very challenging question. The first thing we do with our patient is to be sure that we have their commitment for the follow-up. It's very important. I have to say here, Dana, that our more important supporters are our endocrinologists. Now we have to stop them because they stop. It's too many patients under SADIS procedure because they are seeing, the medium long-term results, even though they change a little bit, supplementation. The doses of vitamin D, they increase the calcium doses in our SADIS patient compared with the wrong way and even, with our standard duodenal switch. So it's regarding the supplementation. Regarding the selection of the patient, my message to the audience will be, if you see a patient for the first time, and the patient is very overweight, BMI over 50, some metabolic comorbidities, don't think in a Roux-en-Y gastric bypass. Think in a SADIS or think in doing a sleeve, and then, wait and see. But because if a Roux-en-Y gastric bypass fails, it's a nightmare. We all of us, we know. And there you guys at the state, you have 50 years history of Roux-en-Y, a huge number of Roux-en-Y gastric bypass, and some patients are failing. I think this is the main reason because you are now in almost 60% sleeve. Is that right, Dana? I think, it's one of the main reasons.
Yeah, that's certainly the numbers in the US. I mean, our practice had historically been and still remains fairly gastric bypass heavy, but I think that's because word of mouth spreads amongst patients. But I share your opinion fully. The failure pattern of gastric bypass is very difficult to manage that weight regain, and you get left with some poor choices as to how to then surgically manage that afterwards. And so I think thinking long-term of obesity as a chronic disease is these work out to be better strategies. So perhaps is Dr. Zhu from China on the line to maybe comment on the Chinese experience with SADI and any questions for Dr. Torres? All right, Dr. Crow, do you have any comments?
Yeah, excellent lecture, Antonio. Kind of along Dana's comments, I think the data is compelling, both as a primary procedure for the heavier and difficult metabolic disease patient, and certainly as a revision from sleeve versus Roux-en-Y gastric bypass. But when you perform a primary SADI, and I'm asking this question having moved from the United States to the UAE, are you more careful about not just the likelihood that the patient's going to show up again, but do you have specific conversations about protein calorie malnourishment and how specific diets may need to be augmented in protein if they're going to undergo a SADI? How different is that conversation versus a Roux-en-Y gastric bypass in your practice?
Very interesting question, Matt. Thank you so much for asking me this question, which is very important. I think one of the best or the first approaches for our multidisciplinary team is to investigate if the patient has enough money for buying protein. His economical and social status is very important. So it's going to be a sine qua non condition, to move forward. And then our multidisciplinary team, we talk to our endocrinologists and to get the commitment of the patient for being followed. And of course, you have to be aware that if she or he doesn't follow us, going to be a very important problem. But the question, as those patients are, having some medication for her or his type 2 diabetes, hypertension, dyslipidemia profile, they can understand much better that they can continue having supplementation. They will change, their standard medication for type 2 diabetes or even insulin for having pills. So this kind of conversation is very attractive for the patient, but you have to spend time in explaining the patient a first shot status procedure.
Excellent response. Just a rough number. When you have that conversation, what percentage of the time do you say, this patient's not getting it? I really don't think they're a good candidate for a SADI. Maybe a gastric bypass is safer.
Not very infrequent, Matt. Not very infrequent. Especially in the women. The women, is not, because women, generally speaking, they respond much better to the wrong way gastric bypass. When we see a woman 50 years old, 49 BMI, probably if you do it wrong way with the longer BPD, the biliopancreatic lead, with longer, it's going to be enough for this lady. But the male, very metabolic, 57 BMI, ideal one-shot operation for these guys.
Dr. Torres, one other quick question I had is, one of the things that we've found a little challenging with some of these patients is, with a gastric bypass or say a sleeve, they sort of, struggle a little bit in the perioperative period with nausea and various things like that. These patients have some of those struggles, but there is this period that I find out at the sort of nadir weight loss where many patients are needing more support at that particular moment. And I wanted to see if you have had a similar experience. Any comments about that?
Very nicely, I think, the patient after studies, they don't have this kind of problem now, vomiting, probably because we are less restrictive. Our bougie is 50 for bougie, or if it's a second step, the sleeve is dilated, a little wider than before. This is the reason we don't see even GERD, we don't see vomiting, but when we have to face with that, we treat them in a standard way, like a one-way gastric bypass, ondansetron, and other stronger medication for nausea and vomiting.
Great. Dr. Selleck, do you have any comments from Turkey?
Well, personally, I have made all of these operations, including the SADIs, in a selective group of patients. And we initially started it with BPD. I have learned BPD from Scopinaro himself, which was 12 years ago, I suppose. And in our experience, the BPD and the duodenal switch, what we have seen was actually breaking bones and malodorous smell, and it was all pain. So we gave it up years ago. We don't do that anymore. It was a very tough and painful experience for us. I guess my society is not ready for this kind of vitamin requiring surgery. So we switched our technique from those malabsorptive operations to non-malabsorptive, let's say, operations like the ideal interposition. That's what we have been doing frequently. I guess this technique can be done in a very selective group of patients in my country. We love meat, actually, but my experience with these malabsorptive techniques, it was so painful. It was all osteoporosis and breaking bones, actually.
Okay, thank you, Alper. I agree with you. We don't do BPD anymore. We used to do an open Scopinaro procedure because Nicola Scopinaro came to our hospital to train us. I invited him, many times to Spain, to operating with us. we used to perform open scope in our procedure at the beginning. You know, I'm talking about late 80s, before laparoscopic era, last century. We don't do anymore, you know, BPD, because it's a very short common channel, 50 centimeters CC. So we would like to delete the word malabsorption, because I think nobody in all over the world are doing now malabsorptive procedure. I would like to introduce the term that Michel Gagné introduced a couple of years ago about hyperabsorption, you know, modulating, lengthening the common channel, depending on the patient. And the problem with the iliac interposition is it's very challenging for the surgeon. Alper, you know, you are a very expert surgeon, a very skillful surgeon, but it's not an operation for every surgeon, because you have to do too many anastomosis, a cross mesenteric defect. You know, I agree with you, that's a very nice operation. We decrease the absorptive component of the procedure. But I think, you know, the word malabsorption, you know, we don't see increasing even in the women these doses of vitamin D and calcium. Are monitoring their bone status. We don't see any fracture, any problem, neither increase the osteoporosis frequency in our patients. We have to take care, of course, of this. Follow-up, again, is essential.
Dr. Zhu or Dr. Li, do you have any comments from China? All right, I guess with that, Dr. Torres, thank you so much. Charles, I'll pass it back to you for our next speaker.
Thank you. Thank you, Dr. Torres and Dr. Portinier. So now I introduce the last speaker, Dr. Yang Liu. Dr. Liu is our fellow surgeon in Beijing Friendship Hospital of Capital Medical University. He has started doing OAGB since about 2 years ago and accumulated a lot of experience on that. And he's going to talk about the role of one anastomosis gastric bypass in the metabolic and bariatric surgery. Please, Dr. Liu. Hello。
有没有开声音啊？
好，大概。Hello, thank you.
Yeah.
Hi, everyone. Can you see my screen now?
Yes.
Oh, okay, let's start. Hi, everyone. I'm Dr. Liu Yang from Beijing Friendship Hospital, from Professor Zhang Zhongtao's team. It's a great honor for me to spend some time to talk something about OEGB with everyone here online. My topic today is the role of MGB or OEGB in metabolic and bariatric surgery. MGB is not a new procedure, but this procedure has always been controversial and even some misunderstood.
杨哥，你的那个 PPT 没有动。
This is a survey of 417 surgeons who have not performed this procedure. We can see about 50% surgeon don't do this procedure because they fear surgery may increase the gastric cancer risk. About 45% surgeon fear this procedure may increase the esophageal cancer risk. About 48% surgeons think this procedure may get higher later complication. About 62% surgeons think this procedure will not approved by their national society. But if approved, about 51% surgeons will try this procedure. Let's take a look at the history of the procedure. In weight loss surgery, the concept of a loop gastric bypass consisting of one anastomosis was first introduced by Masson in 1967. This procedure had a wide and short pouch, and the pouch had a horizontal shape. However, the disadvantage of the procedure was exposing the esophageal mucosa to the caustic bile reflux coming from the jejunal loop. Because it was a reflux-inducing procedure, so this bypass concept was quickly abandoned. In 1997, the first MGB was performed by Dr. Rutledge from the US. And this procedure had a narrow and long pouch. Why was it named the mini gastric bypass? Because the procedure initially was described through a mini laparotomy, in analogy with mini laparotomy cholecystectomy. Rutledge published the paper about MGB in 2001. He reported 2-year results of over 1,000 cases. The EWL was 77%, and this procedure was also very good for the medicines of metabolic disorders. In 2002, Carballo from Spain proposed a technical variation for MGB to prevent gastroesophageal bile reflux, and called this procedure anastomosis gastric bypass. The abbreviation is OAGB. He published the paper in 2005. He reported 1-year results of 209 cases. The EWL was 75%. In this study, gastroesophageal reflux was studied by a 24-hour pH test and endoscopic examination. At 12 months after surgery, in the first 20 patients, the results in all 20 patients were normal, so they didn't pursue this measurement and evaluation in the subsequent patients. The latest experts consensus on OEGB has just been published in IFSO 2019. The consensus identify MGB and OEGB as 2 different surgical procedures. First, the length of the pouch is required to be as long as possible in OEGB. The longer the pouch is, the stronger food restriction effect is, and the less likely bile reflux to the esophagus. Secondly, the anastomosis size of OEGB is smaller than MGB. 25 to 35 millimeter stapler length is used for the GG anastomosis. Third, the anterior wall of the pouch is usually used for the anastomosis. The posterior wall is usually used in MGB. In my opinion, the anterior or posterior wall is not important. MGB is an end-to-side anastomosis. OEGB is more like a side-to-side anastomosis. The importance of measuring the whole small bowel was emphasized in OEGB. Finally, the biggest difference is that the afferent limb need to be sutured in the upward to fix about 5 to 7 centimeters. The purpose of this step is to prevent bile reflux. At present, OEGB has been recognized as a standard bariatric and metabolic procedure by IFSO position statement. OEGB also has been endorsed a bariatric or metabolic procedure by ASMBS in 2018, but IRB or IRB exemption is required. According to the IFSO World Survey in 2016, about 30,000 OEGB cases were performed worldwide, accounted for about 4.8% of all the procedures. OEGB accounted for about 10% of all procedures of Europe in 2016, 4% in Asia, 8% in South America. Because OEGB has not been endorsed by ASMBS and covered by the insurance company, So no OAGB case was performed until 2016 in US. At the same time, we can see that OAGB is on the rise except SD in all kinds of procedures. Professor Vijay Lee reported 15 years experience of OAGB. His retrospective data suggested that the weight loss effect of OAGB was better than SG and RUY in 2 and 6 years after surgery. Interestingly, there was no difference in weight loss between the 3 procedures after 7 years. Professor Vijay Lee's another retrospective study suggested that OAGB group weight loss and diabetic control effects were better than RUY group in 1 and 5 years after surgery. Especially for the low BMI patients, OAGB can achieve much better diabetic control effects than RUY. This is a single-center RCT study performed by Professor Vijay Lee in 2006. Each group had 40 cases. Its 2-year results suggested that OAGB could get better EWL than RUY in 1 year after surgery. The operation time and the early complication rates of OAGB were less than RUY. Because OAGB is easier to operate, there is only one anastomosis, and the anastomotic position is lower, so there will be fewer anastomotic complications. This is the Omega trial. Its results confirm that OAGB has no inferior effect to RUY in weight and diabetes control, but the malnutrition rate was higher in OAGB group. Why OAGB can get better weight loss and diabetes control, but more malnutrition problems? It may be related to the longer BP limb in OAGB. Usually, BP limb is 200 centimeters in OAGB. What is the appropriate length of BP limb in OAGB? This study revealed if the BP limb is 150 centimeters, the malnutrition rate was 0. If the BP limb is 250 centimeters, the malnutrition rate was 0.6%. This study also found the lowest malnutrition rate of about 6.45% was seen in BP limb, the 150 centimeter group, and also can get good weight control. This is another study performed by Professor Vijay Lee. It found measuring the small bowel length may decrease the incidence of malnutrition after OAGB with tailored bypass limb. First, the whole length of small bowel was measured to ensure a common channel length between 400 to 600 centimeters. The BP limb was 150 centimeters for BMI no more than 35, and then with a 10 centimeters increase for every BMI unit increase, instead of using a fixed limb for all patients. Group 1 used the fixed limb, Group 2 used a tailored limb. We can see Group 2 had a much lower malnutrition rate than Group 1. Bile reflux and marginal ulcer should be the most controversial part of this procedure. This paper reviewed the 7-year follow-up results of 1,000 cases of OAGB. The incidence of bile reflux and marginal ulcer were 0.7 and 1.7%. This article reviewed more than 2,000 consecutive cases of OAGB. A total of 32 patients, about 1.2% patients underwent a conversion from OEGB to RYGB for bioreflux at a mean of 30 months from the OEGB. Interestingly, another study compared the bioreflux frequency in OEGB and RYGB. A total of 122 obese patients who had undergone RYGB or OEGB surgery were included. The Sydney Bioreflux Index showed no statistically significant difference between RYGB and OEGB groups. Similarly, no statistically significant difference was found in the self-reported history of bioreflux-related symptoms. Bioreflux marks in endoscopy and post-operative complications between the two groups have no difference. Conclusion: there is enough clinical evidence to support OEGB as a recognized bariatric or metabolic procedure. OEGB is on the rise in recent years. Bioreflux is the most controversial part of OEGB. The malnutrition rate was higher in OEGB than RYGB. I think there is no perfect operation, the same with OEGB, but this procedure is worth trying. Thanks.
All right, thank you so much, Dr. Liu. And first discuss, I think Dr. Zhu Shaihong is online finally now. So we have a few hospitals in China starting working on the OEGB since past 2 years. So do you have comments on that?
Yeah, thank you, Dr. Charles Zhang, and thank you, Dr. Yang Liu. Thank you for your presentation. I haven't doing the operation for the OEGB yet. I just doing the sleeve gastrectomy and the gastric bypass. As you mentioned about that, the OEGB I think is more simple than the bypass. If the result is as you mentioned, we need to give up bypass for others. Also, from the another lecture, Dr. You mentioned about the studies might be a perfect operation for the metabolic surgeon. We need to give up sleeve, give up bypass for others. I'm not sure. Because in our lecture we are all surgeons, and the choreologists. For the bariatric surgeon, maybe we need to think about focus on the alert function. If the patients have a obesity, metabolic disease, he has a diabetes 2, and if the diabetes 2 is caused by the ethnic resistance, I think every operation, sleeve, bypass, studies have a very good result. If the alert function is impaired, is damaged, the C-peptide is less than 1, maybe the metabolic surgeon might be what kind of operation, whatever, maybe we don't have very good results. That's my experience. Maybe for the diabetes patient, we focus on the maybe we focus on the alert function and have a good cooperation with endocrinologist to make a decision. What is a perfect operation for the metabolic surgeon? I think maybe Saudis, maybe Saudis, but is it a perfect operation? Maybe we need to always say what science it is. Maybe we have a more detailed research for the basic research for this kind of operation and also AGB. Thank you.
Great. All right, that's a very, very good comment. You know, we are always looking for the perfect procedure, but looks like we still need to do a lot of research on which one is a perfect procedure. So the OAGB is the most controversial procedure. And we have 3 faculties from the United States, include Dr. Kron, Dr. Portinier, and Dr. Ponce. So what's the current status of OAGB in the United States, and what's the future for the OAGB in the United States? Do you have any comments on that?
I guess I can speak into that. Can you hear me?
Yeah.
So the OAGB is not endorsed, approved by the ASMBS. It's not reimbursed by insurance in the United States, and so it's not widely available. The MBSAQIP, which is our national registry, does not recognize it as a primary procedure, and so it is still an investigational procedure. I do think that the SMBS is going to have to tackle this at some point, because there is now enough worldwide data to start thinking about addressing this procedure. The reason that in the United States is not widely acceptable is because on the early adoption of this procedure in the United States, it was not done in a very ethical manner. You know, there were a lot of cases that were done tricking the insurance company, tricking the patients. Some of the data was not reported. And so it got a very bad PR in the United States initially. And so it's been taking a lot of time for the SMBS to get back on track to this. So experience in the United States is very minimal. A number of cases are very few. People are doing this, surgeons are doing this, that's probably doing it outside of the insurance protocol. And maybe some of these are done as a cash patient option.
And to piggyback on what Jaime said, I think that, you know, all those issues exist. And, you know, the mini gastric bypass originated in our kind of area here, and the insurance companies all have specific statements in their policy saying that they cover most of the bariatric surgeries, but specifically do not cover the mini gastric bypass. And the fact that it's a loop and the SADI or the SIPS is a loop has also created some confusion amongst insurance companies with those procedures. So I think there are a number of hurdles to overcome, but as Jaime alluded, there's lots of data, and as a result, lots of interest among surgeons.
And then maybe I'll just add kind of some connecting comments. Is an American surgeon, but practicing in the UAE. There's a lot of one anastomosis gastric bypass performed in the Middle East and Southeast Asia. As a referral center here, and with a high volume of revisional surgery, we've actually converted a lot of one anastomosis gastric bypass and minis back to Roux-en-Y for several complications. One is bile reflux, anastomotic complications, ulcer, leak, but also for protein calorie malnourishment. And I think this goes back to my previous question for Dr. Torres, is that I think it's a very powerful operation in terms of treatment of comorbid disease, and from a hypoabsorption or malabsorption standpoint. It has to be very carefully vetted with patients. They have to understand what that anatomy looks like. And I think we're still in the early learning phase in terms of what those limb lengths should look like and what the ideal follow-up should be. So for those groups that are doing high volumes of these, I think it's incumbent upon them to publish the results so we can really make some data-driven decisions.
Dr. Torres? Okay, I think he's probably lost the connection. Dr. Salik, so do you have any comments? Well, what about mini gastric bypass in Turkey? What's your position on that?
It gained popularity in Turkey. And actually I have personally performed 134 cases in the last years, and I stopped it in 2016 because of more than 10% of patients requiring revision due to severe reflux. And I also have the same concern as the surgeons from United States, that the publications related to one anastomosis gastric bypass or mini gastric bypass is not very intense. What we have seen was more than 15% of iron deficiency anemia and 15% of cases requiring revision due to severe reflux. That's why we stopped it 4 years ago. We don't do that anymore. And I don't know how many of my patients went somewhere else for their revision, but the question is, what I do in an interposition case is just a 50 centimeters of jejunal bypass, and I have around 11% of iron deficiency anemia with a 50 centimeter bypass. So I don't understand how the patients can achieve a less than 5% of iron deficiency with a 200 centimeters of bypass. I can't understand it. But one more issue about the mini gastric bypass is the leak of the gastrojejunostomy in a Roux-en-Y gastric bypass is not the same thing as a leak in a mini gastric bypass. Because when your Roux-en-Y gastrojejunostomy leaks, you will have less than 1% of mortality. But when you have a gastrojejunostomy leak in a one anastomosis gastric bypass, that's hell. I can tell you that. So this was not the reason to why we gave it up, but the reason is severe reflux, nighttime reflux, that turned some of our patients' life to hell. So we don't do that anymore.
So is there any patient that had gastric cancer after mini gastric bypass in your patient series? Dr. Selig?
No cancer,
no,
just
okay.
one case of perforation, but
okay.
It was a benign ulcer.
Okay. Dr. Manuel, any comments our surgical tour?
Can you hear me? Can you hear me?
Yeah.
I think it is Antonio.
I'll try to.
Antonio's on the car.
Can you hear me?
Yes, we can hear you.
Oh yeah.
Drive safe.
Okay,
yeah,
thank you. Yes, answering, Matt's comment. As I mentioned during my talk, we don't perform one anastomosis gastric bypass, but the reason because we don't know any advantage. In the study we performed with the German colleagues, almost 1 every 4 patients were complaining about by reflux. I know there is no cancerogenic. There is a lot of study for the one anastomosis gastric bypass guys saying that there is no cancer, there is no barrel, but many of our patients we followed and we interviewed they were complaining about having green pillows the morning after. Early in the morning, I know my pillows are green. So this is a complaint that the patient are commenting. And I think another issue of the one anastomosis gastric bypass is to perform an hyperabsorptive procedure without knowing the length of the common channel. In my opinion, going to be the most important cons against this procedure. But anyway, I know that many people are performing. There are many data, and my opinion is the same as Manuel Calva's opinion. The world is so wide. There are so many patients, and probably we have to look for the proper place for the one anastomosis gastric bypass. It's my opinion.
All right, great. Dr. Manuel?
Yes, I'm here, sir.
Yeah.
So let me, what is the situation in Brazil? So Brazil is a predominant Roux-en-Y gastric bypass country. It's the second world largest bariatric surgery market. And sleeve gastrectomy is gaining popularity. Most of the surgeons for the preferred is the Roux-en-Y gastric bypass. So the OHB is slowly getting to the country by the hands of Armino Ramos. So the way he did that is by means of a prospective randomized control trial on a very important university here in Brazil. The results are about to be published. So it's gaining popularity, but I can tell you that it's very, very small. What I can witness for you is what I saw in India, a way for the index surgeon, but it seems that quite some Indian surgeons had perfected the technique, and it's widely adopted. And if I'm not wrong, I think it's one of the possibly the most performant procedure there, and they're doing more and more. And I think, yes, no, not a single procedure is perfect. So you see this huge issue that is now coming with sleeve gastrectomy, that is the reflux. Bypass has the bowel obstructions, and mini gastric OHB gonna have its own problems yet. So nothing is perfect, as well as our bariatric endoscopic procedures. And I think this is a matter of doing and perfecting that. So each other country, each other service will have its own issues with that. What I can assure you, by being on the other side, like fixing complications, my dear friend, is that and this is for you, Alper, and for many of us. Being a master on the other technique doesn't make you automatically a master of the new technique. So it's a matter of getting to that and perfecting the technique. And I saw that because I am, the cases are sent to me when they complicate. And I see that masters on one technique, when they jump on a new technique without the proper preparation or the willingness to really embrace the technique where the way it should, and not having their own bias that I'm gonna do it this way. So this comes. So what I see is when people embrace the technique, perfect the technique, all of those techniques are valid and can be performed if you select well the patients.
Great. Dr. Li Peng, Dr. Peng Li, have any comments?
To learn a lot, but no other comments. Thanks. Yeah.
Okay, great. So any comments from our panelists, from our faculty before we concluding our webinar?
Just one word. It's not a comment actually. Just to remember the name Garcia Caballero, who was the pioneer of his own Bagua technique, which was a kind of one anastomosis gastric bypass. I just want to say, Garcia Caballero, rest in peace. He was a lovely man who passed away in the last few years ago. I suppose it was 2019. I just remember his lovely face. And I
support your comment, Alper, because this guy is from Spain, and this guy is coming from the same city where he was born. It's Malaga, the south of Spain. I support all your words. He was a very nice guy, and he worked very hard for promoting his procedure. And also, you know, Miguel Angel also going to be in Valladolid, going to see also a very Carvajo, you know, all of you know these guys from Spain, they promoted all this procedure. But anyway, I have some reason for you know, for respecting them in all these things. Thank you for your work. Thank you for your work.
Thank you. Yeah, it's a good memory for us. So we are now about 15 minutes delay, and thank you everyone, including our faculty members and all the audience, and also thanks Panther Healthcare for supporting this webinar. Now I invite Dr. Zhongtao Zhang for the closing remarks. Dr. Zhang, please.
Okay. Thank you everyone for contributing to this webinar. It's a long webinar. We are so dedicated. Today's webinar is very informative and successful. Also, metabolic and bariatric surgery has more than half a century's development history. It is still a young subspecialty in the field of surgery. Innovative technologies and techniques emerge frequently. As a bariatric surgeon, we need to keep learning and adopting new knowledge and techniques in order to provide up-to-date treatment to our patients. Thank you very much again. Wish everyone successful in your career development. Please stay healthy and stay safe. See you soon. Thank you. Thank you again.
Thank you. Can everyone turn on the camera? We take the group
Thank you.
picture. Everyone, please
Yep.
turn on the camera. We take the group picture.
Okay.
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 We're getting there. We are getting there. More people?
Yeah, more people. Okay.
Pause.
Smile.
Smile.
Please. Okay. Great, great.
Okay, bye-bye.
Bye bye.
Bye bye.
Thank you.
Bye.
教授，谢谢，
谢谢张教授啊，张教授。
谢谢，拜拜。
嗯，
Bye.
Bye.
Thank you. Thank you.
Thank you.
See you very soon.
See you soon.
辛苦了，辛苦了，张主任。
在哪里？我没
谢谢，辛苦了。
哎，邵长，谢谢，谢谢，谢谢，谢谢。
超时太多啊！
哎，
太多了。今天这讨论很热烈，所以
是
想把大家都叫出来发言，结果就是太太热闹了。
嗯，
那国内做这个 ESG 和这个还是比较少，就是和这个placation 就这个这个水球呢，人比较期待，然后现在病人实际上也打听的也挺多。
那个巴辛的教授大概2年以前在江苏省医院做过一例 ESG， 就是今天的那个巴辛的教授，对，
对，我看他们的经验比较多。另外，我一直在想，他这种 ESG， 我看到刚刚那个就是那个刘勇教授，然后他是在动实验做了一些，但是在人上他好像是不太倾向于做，还是什么个意见？
没有，现在还没有批准。
怪不得。实际上以那个在考虑上，我也比较担心这个什么。这个我们的内分泌像左慧丽左主任他们，我只和他们聊过几次，他们也想做，但是也比较担心，因为他们做早癌比较多，也担心这个再过他10年20年会怎么样子。
OK， 下来再聊吧。
OK，
拜拜。
Good night。
有空再聊。
Good night。
Thank you, Charles.
Thank you. Thank you, Dr.
Dr.
Yeah.
Thank you.
Thank you, Dr. Zhu. Yes. It was great. Great to see everybody over the video today.
Good to see you again.
Yeah, hopefully one day we can actually see each other in person again.
Yeah, Malta. We got time to do Malta again, you know?
Yeah, you guys can come to Duke anytime, or I'm, of course, happy to come back to China.
Yeah.
You're welcome.
Yeah.
I'll save a lot of Malta for you.
Okay, that's good. That's good. One day we'll have to have a glass of Mai Tai with a Panther stapler in hand here at Duke.
You will have
that. Maybe I shouldn't use the stapler and the Mai Tai at the same time.
Sure, why not?
All right. Well, it's great to see everyone.
Okay, great.
Great.
Take care, everybody. Take care.
谢谢主任。
谢谢主任，辛苦了。
好，你们谢谢你们，
谢谢。
好。
哎，从哪里？